I want to start by, I'm Miller Piggott. I'm the Executive Director of Alzheimer's of Central Alabama. And we decided to hold these webinars because this seems like a great way to reach out and to provide some continuing education right now. We normally have a conference in the fall, and obviously that's not going to be something we think that is going to be possible this year. Katie Cochran with Home Instead, give a wave, Katie, so they know who you are. Katie is helping us with CEUs, and we're very, very glad to have her. Katie, do you have some housekeeping tips you would like to give us in terms of CEUs?
Sure do, Miller. I'm glad you asked. Let me figure out how to share the screen.
And for those of you that don't know, this is our first session that we've done like this, and so we're on a little bit of a learning curve, and thank you for allowing us to work out all the kinks.
And that's just a black screen. Hang on, friends.
Well, while Katie is doing is finding our information on CEUs, let me go ahead and introduce the two people that we've asked to speak with us today. Paige Ensor is the Vice President of Operations for Greenbrier Senior Living, and Nick Beckham is a Regional Administrator for NHS Management Company. So I just want to say, oh, well, there we go, Katie. I'll let you talk and then I'll talk.
Sure? Okay. If you are on this call and or this meeting and you need a CEU, here are the things you need to pay attention to, please. And I opened up the wrong one, so I'm going to have to verbalize some of the things. You're going to email, if you are a nurse or a social worker, email your license number and your name as it appears on your license to, it's to Sherry Sparks, and the address is, I'll put it in the chat, but it's aca2@alzca.org. I'll put that on the chat as well. And after you complete this, there will be a survey that will be sent to you. And it's more important for the people who are getting continuing education credits to fill out that survey. We'd love to hear from everybody else, but those that are getting a CEU, please fill out the survey by 5 o'clock today. And once you fill that out, we will know that you're all good as far as attendance, and we will send you a certificate of completion on Monday. And that, I think, is all. And I'm going to put that stuff in the chat, the email address.
And also, Katie, I want to be sure everybody knows that this webinar will be archived and will be available on ACA's website starting on Monday as well. And so I think that's another great feature. CEUs are not available once you view it in the archives, but I think that there might be a lot of families and other people who might be interested in hearing from Paige and from Nick. I want to start by saying this morning I watched the Community Foundation's webinar with Dr. Michael Sagg, who's an infectious disease specialist at UAB. He also had coronavirus early on in the pandemic, and he had a lot of very interesting things to say. It was really a question and answer kind of thing, but here's the big message. We had a huge spike in cases yesterday, over 800 cases here in Alabama. That is more cases than were diagnosed in all of Germany yesterday. Dr. Sagg gave Alabama an F in our social distancing and wearing masks. And I think that's something that we all really need to think about. And he had a graphic that he did with Pigpen from Charlie Brown. And he said, just like that aura of dust and dirt around Pigpen, that's what it's like when you're infectious with coronavirus. You have got that same kind of glow about you, and that's why you
Hello.
wear a mask, is to really prevent that. He also said during that time that he was ill and was quarantining at home, that he and his wife were very, very careful to wipe down every surface and not touch anything, but he didn't wear a mask, and she became infected. And so it's really the mask wearing that's the most important thing, and that's what we need to think about when we're at the grocery store or anywhere else. So I just am really looking forward to hearing what Paige and Nick have to say, because our families who have got loved ones under their care and in the care of other facilities like theirs have really struggled during all this. And I think a lot of questions feel like they've been unanswered, and this gives an opportunity for y'all to share that. I'm going to introduce them both, but then we're going to hear from Paige and then from Nick, and we sure want to get y'all's questions too. So Paige is been with Greenbrier for more than 20 years, came to Greenbrier with more than 20 years of experiencing, progressing from community level roles to senior executive positions for multi-state organizations. She most recently served as Regional Vice President of Operations at Morning Point Senior Living. She's also been a vigorous industry advocate, speaker, and leader. She was responsible for launching the Tennessee chapter of the Assisted Living Association and served a term as its executive director. Nick is a regional administrator with NHS Management and is responsible for the oversight of 9 skilled nursing communities across the state. He has spent 13 years in the skilled nursing industry and has experience with short-term rehabilitation, long-term care, and memory care. So Mr. Nick is active in the industry in the skilled nursing sector and currently serves as a board member. Y'all, he is our board president for the Junior Board of Alzheimer's of Central Alabama. It is an awesome group of folks. They are funding 2 pre-doctoral scholars at UAB in Alzheimer's disease research. And Nick has really been instrumental in helping us raise the money to make that possible through a golf tournament that I guess we can't have this year. That it's hard for me to even say those words. We can't have it this year, but we really can't. And an Ales for Alzheimer's event that we have at a local brewery. So like many organizations, you know, both are what we call our big board, which is the large group that oversees ACA, and our junior board. We're all struggling for how to move forward, how to continue to have events that are safe, how to raise money, and most importantly, how to continue our activities. So thank you, Nick, for what you've done for the junior board. So Paige, I'm going to let you go ahead and fill us in on the assisted living side of COVID-19.
Absolutely. Thank you, Miller, for the great introduction. And Katie, thank you for your orchestration and assistance on the technical support. I do want to make this a fun, a participatory event for all of our attendees on the call. I will ask if Katie or Miller can read questions. Feel free to interrupt me as I'm going through this slide presentation with any questions that pop up in our chat box. It's nice to see all of our attendees that are on right now. I'm going to go ahead and share my screen. And as I'm sharing my screen, I just want to share that Greenbrier, we have communities here in the state of Alabama that we support. And a lot of our other locations are primarily in the Southeast. We do have some outlying communities in Colorado, Minnesota, Wisconsin. So if anyone is on this call is outside our state, I'll be happy to speak to what's happening in other states as well. Can everyone see my screen?
There we go.
All right, let me go back to the beginning of our slide presentation here. There we go. And I do not know why it's showing a split screen, but I'm going to apologize in advance for that. I don't know how to turn that off. But I do want to talk about our move-in process, what we're doing in our communities regarding move-ins. I know everyone's doing things a little bit differently across the states with testing becoming more and more readily available. and the accuracy of testing. But primarily what we do at Greenbrier is for our independent living and our assisted living move-ins, we ask that the family members proactively go ahead and move items into the apartment and quarantine at home if they're independent living or assisted living. And we will test them pre-move-in. So we're asking them to come to the community, or we'll go to the home and we will perform a COVID-19 test. Once we have notification that that test is negative, what we will do is we'll call them, notify them, and say, congratulations, you're negative, you can move in. They have 24 hours to move in after that notification. Once they move into the community, we ask them to continue to quarantine, and we will test them a second time on day 5. And that's day 5 post the initial test. And the reason why we are testing them on day 5 after they move in is we want to make sure there's not a viral load. And once that resident comes back negative on the 5th day of testing, they can come out of their apartment and participate in social distancing activities if the state allows that. So all states, as everyone is aware, is in different stages of opening up America, and there's different phases, and states are following the White House model. It is a little bit different for our memory care residents. Memory care residents, we are asking to quarantine at home with a caregiver. We're recommending that caregiver be either a private duty sitter or a caregiver, a family member. So it could be either or, and it needs to be the same person. And the reason that we're recommending the same individual is we want to reduce risk of exposure. We issue paperwork similar to what we do in our community, such as a sanitation list. They receive a temperature check log, essential personnel in case there's home health coming into the home. There's a worksheet that's completed before the essential visitor visits the home. But both the caregiver and the residents at the beginning of the quarantine period receive a COVID-19 test. They will commence quarantine once we receive notification that that resident is negative. That resident moves into the community, and we cannot, to quarantine a memory care resident, we cannot do that, but we do go ahead and test the resident post move-in and monitor to make sure there's no symptoms of COVID-19. Visitation, as we stated earlier, is different in all of our states. This is the state of Alabama. And right now, they're not recommending in the community visitation. We're doing outside visitation in our communities. And we have a community here in Birmingham that did an outside visitation setup, which worked very well. We did talk to the state, and we social distanced outside, and we had plexiglass in between the visitor and the resident. And that's working very well for the community here in Birmingham. Miller or Katie, has there been any questions so far? Okay. Greenbrier, we follow the CMS opening model, the recommended CMS opening model that follows the White House opening up America phases. And so our opening up in our communities is very similar to that model as far as each phase. We're recommending for when visitation opens up in the communities that the communities notify proactively family members, and family members sign up for visitation times, that we identify visitation areas within the community, a room or a library that is close to the front. Visitation occurs in those areas. So when a family member shows up, they're tested out in the car, their temperature's checked, their oxygen's checked, they fill out the questionnaire. A family member, if they pass all those things, are escorted to that visitation area. The resident proceeds with visitation with the family. Both have masks on. That's very important, as Miller was discussing earlier. And after that visitation ends, we sanitize that area and prepare it for the next visitor. And there's a checklist that's used in between visitation. There are recommendations on the CDC website for opening up different areas of your community, and we are following those. There's some very good guidelines for the dining room, chapel, your workout areas, your beauty shops. We've had so many questions about hair. Hair has been a big issue in our communities, and how we have been working around that is a lot of times the beauticians, they are not allowed to open their business depending on the phase, and they're cited if they open up the beauty shop. And they're considered non-essential coming into the communities. So what some of the communities have done is that we've hired the beautician as an associate, and beauty is care planned. So that's been a way we've been able to address everyone feeling well and having their hair cut and looking pretty while they're quarantining in the community. Reopening dining. When the communities are open to do social distancing dining, we separate tables. We do have a whole process for this, similar to what you experience if any of you are visiting restaurants. We check temperatures at the dining room. We watch residents sanitizing their hands. We do have stickers that we place on the floor. You can order stickers through different companies, Direct Supply, McKesson. And the chairs are set up for social distancing to help prevent anyone sitting close together. And we monitor the dining rooms to ensure that we don't have more than 50% occupancy in the dining areas. And we set the tables with, between each sitting, there is not any condiments on the tables. We don't bring ramekins to the tables. We minimize any chance of cross-contamination or having items on the tables between resident use. So you can see there's a whole program that we have for dining. Exercise centers. Again, I talked and touched on that earlier regarding the exercise centers. With Opening Up America, there are some good things on the CDC website for the phases on how to use your exercise center, but it's similar to the visitation program. Hospital transfers. Each state, we've had a little bit different experiences in all of our states. Alabama has been a wonderful state to work with. We've had some issues in Texas, for example. We had a community in San Antonio where we've performed baseline testing, and the community was COVID naive, meaning we didn't have any cases. However, with our testing, we are seeing a lot of residents that are asymptomatic. And with comorbidities, if a resident is diabetic and they're asymptomatic, or we find out that they're COVID positive, often we will ask them to go to the hospital. And most of the time, our hospitals admit those residents. And in Texas, they're not admitting residents. They're routing them to a hospital that is a COVID designated hospital. And in Texas, they refused to test our resident a second time. And we wanted that second test to make sure that it was not a false positive. So that resident ended up coming back into the community, quarantining in their apartment, and we went through the testing process at the community and set up a negative airflow in the apartment and put them under isolation precautions and droplet precautions. Typically, when residents return from the hospital, we're following the recent CDC recommendations. If someone is COVID negative and they're in the hospital, we ask for one COVID test, typically within 72 hours before discharge back home. Someone's COVID positive, they're receiving 2 tests within a 72-hour period, and they need to be negative before they're discharged back to the community. All of our locations nationally, the past 3.5 weeks, we have started baseline testing. And we purposefully waited to do that for a few reasons. One is we were looking to make sure that the test was accurate. We were looking at different labs. We were noticing a lot of other providers in our space were using tests, and they were getting a lot of false positive tests. And at the same time, they were having to report those results to the state. And even though those tests were false positive, it elevated state visits. It caused a lot of resident anxiety, associate anxiety, and family anxiety. We did find a lab that had great availability of resources and was also waiving any associate testing due to a grant, and their tests were 99.8% accurate. So we proceeded to do baseline testing proactively in all of our locations. Some states, such as Florida, it's mandated. And after we perform that baseline testing, we are continuing to do random testing of 10% of our associates and 10% of our residents weekly. With performing, I'm sure Nick's going to talk a little bit more about his experiences, but with performing in our communities, the testing, what we've learned is a lot of tests do come back positive, but interesting, a lot of our residents are asymptomatic, or our associates are asymptomatic. They're not exhibiting any symptoms of COVID or don't ever present any symptoms of COVID. Here's some different links that are very beneficial. I know that Miller's recording this. They might be helpful to you. So are there any questions I can answer?
Paige, I'd just like to clarify that even people who are asymptomatic, whether it's your staff or your residents, that there's still a period of time where they could be contagious.
That's exactly right.
And
so if they're asymptomatic, we treat them as just like they're a positive COVID-19 case, regardless if they're showing symptoms or not. So associates are at home. The residents are quarantining in their apartment under isolation. We use full PPE when interacting with that resident. We create negative airflow in the apartment. How we're creating negative airflow is we have a fan. We have the fan facing in the window exterior outside. We put a seal around the fan. We also put HEPA filter towers in the apartments to scrub the air that have UV lighting and pull the air through the tower. So that's something that's very much helped in the apartments with the air, keeping it scrubbed, or scrubbers. You can use scrubbers. And then we retest the resident and retest the associates until we receive 2 tests that are negative. And we test once, test again within 24 hours. And if both of those tests come back negative, we consider them negative.
And Paige, can you tell us how your families have been during all this, and what kind of support any family should expect from their retirement community?
Families, let me speak to positive cases first. Positive COVID cases, whether it be with the associates or residents, the key is to tell the story before somebody else tells the story for you. And we don't do a mass email when we have positive cases or a call out. We do have that availability, but we purposefully call everyone individually and speak with them. And that has managed anxiety. We have families thanking us, and they're so appreciative. And thankfully, we've not had any media response because we have been so proactive with our communication and one-on-one with our family members and our associates and our residents. We still have families call in different states going, I want to see my mom. Why are you preventing me from visiting my mom or my dad? It's my right. And even though we're educating weekly with call outs and with our newsletters, and we're pointing to our state resources, families do miss that. And so we still get those phone calls, and we talk with those individuals one-on-one when those phone calls come in. And some people understand, and when you explain it to them, they're okay. But unfortunately, there are those who are just never going to understand. And we just have to work one-on-one with those individuals.
Katie, have there been any other questions that we need to?
I have not gotten any questions.
All right. Well, Nick, are you ready to tell us some about what's happening in nursing homes in Alabama and the places that you have visited and you're trying?
Sure. Absolutely. Yeah. What I'll try to do is just kind of give a general summary of the state of affairs for the skilled nursing sector, as well as what some of our individual responses have been, and also just kind of where we are as an industry. And I'll try to structure that around questions that I receive most often from families and other partners in the industry. So if you have any questions here, I don't have a structured agenda. So if there's something that you want to know about as I'm talking, put up a question and I'll be happy to answer it. So in general, what we've seen, like Miller said, is the increases in cases. Now that's definitely happening in the nursing facilities the same as it is in the communities. And the reason is that the nursing homes really are reflective of the community that they're in. We've looked at a lot of studies that spread in the different nursing facilities. And we also want to know where, we have cases. Do we see that as a potential issue with infection control in that given facility? A lot of the state surveys, federal surveys, CMS are also looking at that. Or is it more reflective of the cases in that general geographic area? So far, the evidence is pointing towards that quality measures and indicators from recent surveys have not been indicative of a decrease or increase in spread in homes. It's really been almost mirror image of the community it's in. For example, when the spike in cases were happening here in the Jefferson County and Birmingham area in Alabama, we saw almost a mirrored percentage increase about a week to 2 weeks later in our skilled nursing facilities. And the reason for the lag is obviously we're still following visitation restriction in all of our facilities to protect our residents and our most vulnerable. And the only people that come into the facilities are the medically necessary, which would be your physicians, your nurses, the nursing assistants, anyone doing direct care, therapists, those type things. But they live and work in the community just like everyone else. So they're going to the grocery store. They're doing the best they can, just like everyone. We encourage them to follow safe social distancing practices and also infection control practices, both inside and out. But our employees and physicians and nurses all consist of people that live in the community. So when you see an outbreak or a spike in case numbers and percentages, we see that case outbreak numbers in the facility as well. Typically there's a lag because they have to wait till the virus develops before it starts showing symptoms in our facilities. What we're doing to protect is multifaceted. Number one is a visitation restriction. So if you're not medically necessary, you're not allowed in any of our facilities. That's been a very tough thing for us, for our residents, for our staff, for everyone involved. As Paige mentioned, that's something that none of us want. Their families want to see their loved ones. Residents want to see them. We want them to come in, but we've done everything we can to kind of lessen that blow. We've got Skype set up, FaceTime messages. We send out a lot of interactive material to our families so they can see their loved ones, not only in just one-on-one conversations, but also just anything that we're doing in engagement, so that they can see those things. We're really active in our social media so they can get updates. We try to send daily and weekly notifications out of just general what's happening in the facility. So that's...
I'm sorry. I have a question. Can you explain what would be medically necessary? Like what qualifies as medically necessary? Sure.
The most obvious ones are a physician visit, physician visits, checkup, history and physical. Along those lines, the nursing care. So obviously the charge nurses and the CNAs providing the general care. If a patient is here for physical therapy, then the therapy visits would be considered medically necessary. Things that aren't as obvious might be specialty type visits. So for example, a person, we want to restrict their out of the facility movement as well, but if a person is on dialysis or has a specialty appointment, that obviously those services are needed but cannot be provided in the nursing facility, then they're sent to those visits, and we put them in protective equipment, including a mask and gown, and send them to their visits, and then bring them back, and we screen them when they come in. We screen everybody. The only time that families or visitors can be considered medically necessary is the number one reason is end of life care, in that a person is on hospice, they're a terminal diagnosis, and they're reaching the end of their life. And we obviously want to make sure that they're able to have someone there with them in the event that situation is occurring. And we want them to be able to see their loved ones and be with them. And then we screen that individual. We limit the numbers. And that's both for the family's protection and the rest of the residents in the facility. We do our best to give that person a designated space, and we walk that family directly to that resident and allow them to spend time with them for the end of life. Another might be that you've got a person who has an extreme diagnosis, like a Huntington's disease or something where there's only there's a one-on-one care need there, and skilled nursing facilities don't provide one-on-one care. In that case, that would be a medically approved sitter for that person, where they could cause a harm to themselves or others. And those we're very, very careful about, because we want everybody to see their loved ones. We want to be very fair, and we want to provide that care, but we want to make sure, and we're minimizing that, and we're respecting the CDC guidelines and that restriction. And we have seen that is our number one defense, is just like social distancing in the community, just like staying home in the community, your number one defense in the nursing facility is minimizing the amount of contact. So that's a good question on what is medically necessary, because we'll have a lot of families that'll say, was it not necessary for me because mom gets really upset when I'm not there? And that's true, but it doesn't make it medically necessary. It's more of an inconvenience and a nuisance than it is a medical hardship for that person. So
Thank you.
Sure. The other protection measures we have in place, we screen everybody that comes in the building, whether you're a doctor, a contractor, a nurse, an employee, anybody that comes in the building. You have to go through one entrance. We want to make sure you don't have a temperature. We check, we do a questionnaire, which the questionnaire consists of things that you might have all seen, which is, have you been in large crowds? Do you have any new coughs, any new respiratory symptoms? Have you been exposed to someone directly suspected of or confirmed with COVID-19? Those are some of the questionnaires that we put out, and we want to make sure that if you fail that questionnaire, you're stopped, and we have to talk to our medical director to see if we clear you to come in. But for the most part, we would send you away and make you get cleared medically to come in. So if you have, for example, if you come in coughing and sneezing, then we're going to stop you at the door and turn you away. And if you come back and you're medically screened and you have a sinus infection and a negative COVID test, then we would allow those workers to continue to work. Another thing is that anyone in the facility, when they're anywhere in a patient care area or anywhere other than, like now I'm in a conference room by myself, is the only space that I can be in without wearing PPE, which is personal protective equipment. That's mask, gown, things like that. Anytime you're around others or you're in a common space, you have to wear a mask. We're using procedural masks. A good question I get from people too is, what is the difference in just a face mask, procedural, and an N95, and when are those appropriate? So the one I'm wearing today, whenever I leave this room, this is a normal procedural mask, same thing you see in an OR. So the whole point you want to think of is these protect others. So N95s are respirators. They create a tight seal around your face. They prevent air from coming in, and they scrub microns or any bacteria or air in the any bacteria in the air, anything that's contagious, droplets. So COVID-19 is spread through droplets. Those droplets can stay in the air. As the example that Dr. Sag used that you mentioned earlier, Miller, around your person. That's what the reason for the 6-foot distance. If you're talking, you're spreading droplets. If you're coughing, if you're sneezing, you're especially spreading droplets. And those droplets will stay in the air for up to 2 hours, and then they fall to surfaces. So if you're away from someone, you're not contaminating them, or if you're wearing a mask and you're catching and knocking down those droplets. So that's the reason for that. If you're working with a contagious COVID-19 person, yes, I can see this message, Sherry. If you're working with a contagious COVID-19 person, then you have to wear an N95 mask. Now that protects others and yourself, because a procedural mask doesn't keep air from going in. If you can imagine, if you're wearing the mask, it can go around the sides, in through the nose. If it doesn't hurt, if it doesn't put pressure on your face like a scuba mask, think of it like, that's the way I describe it to family. If it doesn't apply enough pressure like a scuba mask, or if you've all worn goggles in the pool, if it's not tight, water seeps in, right? And it leaves a mark on your face because it's so tight, and it creates a seal. That's the difference basically in a respirator mask. And when it's appropriate to do that is when you're being directly exposed to something and you're protecting yourself from those particles. The reason all folks should wear masks is you're protecting everybody else. And the theory is that if everybody's wearing them, then there are no droplets to infect anyone. That's the theory, and it knocks down the vast majority of it. So PPE, screening at the doors, limit of visitation. We also heavily monitor. We're obviously caring for the most vulnerable population in our community. Everyone in the skilled nursing is elderly for the most part. They have multiple comorbidities, and they're highly susceptible to diseases like COVID-19 or the flu or anything like that, where they would have a much worse outcome than a healthier individual. So for that reason, we monitor them closely. Paige mentioned when they're positive, they may be asymptomatic, which is absolutely correct. What we've been finding is that most of these are pre-symptomatic, in that they develop symptoms eventually. And by identifying them early through testing, we're able to put them in a specialized unit. Number one, we isolate them from the general population for contamination purposes, which is kind of the obvious. But number two, we're checking their vitals routinely. So even if they look fine, they're getting their O2 saturations checked to make sure their oxygen is flowing through their blood. We're checking their respirations, their pulse, their blood pressure, any change in conditions, because with this disease, we found that there is a myriad of symptoms that are not typical. I think everybody looks for the cough, right? You hear somebody cough in public and everybody runs, but that's almost a myth at this point. I mean, it's certainly a respiratory issue, but the number one side effects that you're seeing are GI, for example, people with GI problems. Some of the earliest and most common symptoms, loss of taste and smell is one of the second most common symptoms. The majority of folks that we've had a positive have not had temperatures. So really? Temperatures are good for when you start exhibiting, but when you're pre-symptomatic and potentially still contagious, they're not having temperatures. We're not seeing that. So it's good to screen those people for that, and everyone's doing that at most establishments. But that would probably be when your viral load is the highest and you're exhibiting the most contagion, by the time you're running a fever and you're having those symptoms. But we've seen so many of those that didn't, and it's really difficult to track the disease and who it's going to affect. We've seen it. Some of our more sick folks have really good outcomes, have no symptoms, and recover just fine. And then we've also seen some folks that you would think are relatively healthy that have had some of the worst outcomes. And it's very tricky, and it's something you have to be very careful and pay very close attention to. So on isolation and admission process, what we do in the nursing home also to protect everyone here is the number one way someone admits to skilled nursing facilities across the country is through the hospital. Some people think that a lot of folks come from home, but that really speaks more towards Paige's industry and assisted living, where people are entering from the home environment. In our industry, 90% of admissions come straight from an acute care hospital. That is where a person may have experienced a stroke, or have had worsening symptoms or weakness or recent surgery that they're having trouble recovering from, and they come to us for short-term rehab. And if they are unable to recover to a point where they're able to return home, then that's when they transition to a long-term patient. So for our processes, that's the highest exposure we get, because obviously if you're in a hospital and you're inpatient, that's where a lot of people go that have high infections. So we treat you as potentially exposed when they come in for your protection. We put those residents in a private room under isolation for 14 days, just to make sure that they don't have a viral load, to make sure they don't start exhibiting symptoms. And if they do, the exposure to the rest of the population would have been minimized, because they would have been placed on isolation and still been able to get full care. Once they're past that, we can integrate them into the rest of the population. If you are positive for COVID-19, most nursing facilities are not admitting anyone who is COVID positive, and most are requiring in fact, proof that you are COVID negative before you admit from the hospital. There are exceptions. If there is a facility that has a COVID positive specialized unit, that facility can admit COVID positive residents. Now, those are rare. I do think that you'll see more of those. Our industry is trying to move towards a solution with the hospital in partnership with them to find places for appropriate placement for these residents and these patients. If you're not medically unstable, the presence of COVID-19 in itself is not enough for hospitalization in most cases. So if you are having any kind of issues that are symptomatic, or you're having trouble with breathing, obviously the hospital will be an appropriate place for you. So it really puts a lot of people out. It displaces a large population of our communities, because they might be nursing home appropriate, but also medically stable. And the nursing homes are very susceptible to this disease. So unless they have a very isolated unit that's designated for COVID-19 with all of the things that Paige mentioned, for example, in our COVID-19, we need separation walls, barrier walls, if you will. Inside the unit, there are air scrubbers that are cleaning the air. We have everyone there is in full PPE, which is what you might have seen on TV or in the hospitals, which is a face shield, N95 mask, gown, gloves, the whole nine from head to toe, anytime they're in the unit and any care they're providing. And then they're changing that throughout that unit. So that's some of what we're doing for admissions. That's some of what we're doing to protect the general population, and how we're separating and doing those things. As far as a lot of people ask me, well, how do the families know what's going on? It seems like we don't know what's going on until it's on the news. And that's not really accurate at all. What we do is we inform all of our families. In fact, now we've got a really good system. If your family is at all, if any resident is at all involved in COVID-19, whether they're test positive, or if we find that they've been directly exposed to another COVID-19 positive person, we call them and talk to them immediately, individually, walk through the process, exactly what's going on with them and what we're going to do for them. And we do that with feedback from that family. If they're just a general population and just want to know, we actually do a complete message alert system that goes out to 100% of our families. It tells them if we have any cases in-house whatsoever, even if it doesn't affect them. We also tell them, let's say if today I had even just one COVID-19 positive resident in a facility, that facility would obviously immediately notify that family. They would notify the medical director. They would notify the Department of Public Health and CMS. All of those things would be public information. And then once they did that, we would actually notify all family members via the text message, and they would get a message saying, this facility X was notified today that we had one positive COVID-19 patient. You'll be notified of any new changes or any new tests that happen. So we're really running a campaign of transparency across the industry. That's our company and others, in which we want everyone to know exactly what's going on and no one to be surprised. We do have some that say they don't know, but if, for example, one resident, that sponsor and the family listed on their face sheet could have all been notified, but their 15 cousins might not have gotten a call from us, which would not be super plausible, but they understandably all feel like, well, I'm her family, why didn't I know? Well, obviously the caregivers are worried about care first and foremost, and then notifying the direct contacts on the face sheet. So that for people with large families and multiple contacts, some of those family members might not have been notified. So we're asking those primary contacts to please let anyone else in the family know. We're not even allowed to release information to them unless they're on a release sheet showing us that they have access to that information, because there is also HIPAA guidelines related to this specific residence. That's another reason we sent out the general notice, so that everybody knows exactly how many we have in house and where they stand. And it also includes, if you are involved in this, you would be getting an individual call so that they can be comforted knowing that we would talk to them directly. Testing is a huge question I get all the time. How much testing are you doing? Is the whole state going to be tested? Are all the residents going to be tested? So currently there's an initiative nationally from the White House that is petitioning that all nursing home residents and staff be tested. The mandatory testing has already begun in our Florida facilities, because the state of Florida has begun there, and they've had mixed responses from that. They've had some issues with labs being overwhelmed. So there's a lot of states trying to learn from that. In Alabama, I think you'll see statewide testing probably in the next 30 days. I really do believe that it's something they've been discussing. It's something that we, from an association standpoint, have been working with the state government to try to figure out what's the best way for our residents and staff to be able to get all of this testing done and get it done timely. So when people say baseline testing, what they mean is everybody in the building getting tested for the first time to establish where you are exactly as a snapshot in time. Then there's surveillance testing. So what I think you'll see moving forward is all residents and staff will be tested. And depending on how those tests go, I think you'll see they don't want to continue to test residents because it's very uncomfortable. It gives the resident a lot of anxiety, and it is actually physically painful when we do some of the swabbing. It goes very far into your nose, and it can cause a lot of pain. I've had quite a few personal experiences with it, and I can tell you it is definitely not comfortable. So our residents, you can imagine, even especially for those that have Alzheimer's, dementia, and don't understand what we're doing, it can create quite a bit of fear, anxiety, and hardship. So the state recognizes that. So we are hopeful that they're going to adopt a practice that we test them once, and unless there is reason to test them again, we don't have to continually test them every single week, because obviously that would be very much of a burden for them. But the staff will probably be tested routinely, continuing on until there is several months without any positive cases in that area and in that facility before they can just continue testing. That's some of the preliminaries. I'm going to stop for a second because I feel like I covered a decent amount of ground, and see if there's any questions or if I need to revisit or touch on anything, and just make sure everybody's awake and interested.
Nick, I want to ask you if it's okay if you could share a little bit of information, like what you experienced yesterday, what your response was, because that was kind of like a day in the life of what it's like to be trying to troubleshoot with a lot of positive people. I mean, and that creates a lot of problems.
Sure, I'd be happy to. So what Miller's talking about is we have a large amount of facilities. We're the largest provider in the state. So we have 50 facilities in total across 4 states, with the vast majority of those here in Alabama. So happy to report that most of our facilities are COVID-free, which is a blessing and that we're all very excited about. But we do have several in some of the more hotspot communities like Mobile and in the Montgomery market that have had significant numbers of cases in the facility. So typically what happens is the way it usually starts is someone might have symptoms or a reason to be tested. So we test that resident or any of those people that are showing signs of being positive. And if they indeed are positive, we test everyone around them. So we do contact tracing. And the way we do that is we establish who was within 6 foot for greater than 15 minutes of this person at any given time over the last 3 days. And that could be even before they exhibited any symptoms. And then all of those people will be selected to be tested. Now, if we find a heavier prevalence, as in we test, let's say that one person results in 10 tests. Well, if those 10 tests result in 9 more persons, well, now we're going to test everybody. We're going to test the entire facility. We're going to skip all steps in between and go to total testing, which we've done a few times. If it produces 1 or 2, then we'll continue the contact tracing. And what we'll do is we isolate those residents or send them to the hospital, whichever is more appropriate and available at the time. And then we will take those employees and they will go home for a self-quarantine for 14 days. So what I've gone through at some of our more difficult situations is where we've had those multiple cases, unfortunately, where we have 10 positive residents that turn into, studies are showing that the doubling rate, which is the time it needs for any given amount of cases to double in number every time, is 3.5 days. So to put that in perspective, and that's for nursing home environments. And part of that is just, we're a close environment. You can imagine in your home, if you get the stomach bug, everyone in your home is probably going to get the stomach bug because you live in close quarters. You're in the same kitchens and bathrooms. And it's the same thing with nursing facilities. We're in very close quarters. So something like coronavirus is very hard to contain. If we have a large amount of cases, we try to make a unit immediately, which might involve several room moves. We might have a room where one resident is positive and one resident is negative, which creates an issue for us because we need to move the positive resident to a COVID unit, but we also don't want to expose that negative roommate to anyone, and because they're more than likely positive and just not testing positive quite yet. What we've had where we've had large amounts of cases, yesterday I had to move 37 patients. And for a room move in a nursing facility, it's not like a hospital where we just roll the bed down the hall. We have their personal belongings, their TVs, their clothing, the bed they were in. We also, the room they're going to is not, we don't have vacant rooms. So we have to move someone out, and you have to move people to a clean space and people to a contaminated space. Then we have to create those isolation barriers. Then we have to notify 100% of the family, like we talked about, notify the state. Yesterday, while I was moving patients, the state survey team actually walked in to our facility. They had not, it was an unplanned, unscheduled visit. We just, I guess, got lucky. And they came in to survey us, and they didn't even realize that we had the cases that we were having. So we had to explain that to them. And luckily, we had a good survey, but we had to stop what we were doing, talk to the survey team, present our clinical information, make sure that we were following all the rules and guidelines, and we came out deficiency free. So that was very good.
Yay.
Hey, it was great, but it was obviously put a delay in what we were doing. So we also have to maintain social distancing for these residents. So as I'm clearing out one space, I have to find a space for these residents to go where they can remain at 6-foot distance. In this case, I use the dining room and some of our common spaces. And then while they were doing that, we had to clean those rooms. And then we had to take positive residents and move them into those spaces. And then we had to build the barrier wall, place air scrubbers, get everyone situated. There's a lot of medical equipment that has to be dedicated and moved to the unit. So if you can imagine, on a unit, we want it to be self-contained. So if you're using a blood pressure cuff, you can't use it anywhere else. If you're using an O2 sat monitor, you can't use that anywhere else. If you're any specific piece of equipment down to stethoscopes will stay on that unit. So we rush supplies into the facility. We have dedicated staff. If they're working on that unit, they don't work in other parts of the unit. So we also have to allocate more staffing to the building. And then once those residents came out of their room, well, that was a COVID positive room. So we have a terminal cleaning procedure we have to follow. They have to be out of the room for at least an hour. And the theory behind that is any droplets that are in the air have settled to surface cleaning. And then we have a team in full PPE, personal protective equipment, that's going to enter the room and do a full terminal cleaning with Virex and everything else that we've got. And we follow a very tight procedure. All touch surfaces, all contact surfaces are cleaned, and then that has to dry. And then we, again, place an air scrubber in, let it clean for a while. Then we could move the 20 some odd residents back into their individual spaces, reallocate staff. But every time we do that, we also have to, you got to think these people live in these rooms. So all their medications have to come with them. All their medications have to be placed on a different nursing cart. Then that nurse has to be reacclimated to every new resident that they now have instead of the ones that they're familiar with their care. Then we move them in the computer system. Then we take all their physician orders and move them over. And then for the COVID positive, we have to add orders for more routine vital checks. We have to get the medical director to write those orders. So it's quite a bit of activity to create these units, and it can be very taxing on both the staff and the residents. We started on this project that we did yesterday at 8 in the morning, and we finished up about 8:30 in the evening just to get those moved.
Well, that sounds like a lot to have gotten done in just 12 hours. Just another question, Paige, to both to you and to Nick. What has this done to staffing? I mean, staffing is an issue all the time. I mean, is this situation made it worse, or is it about the same?
I can speak to our communities. When we've purposely staffed up at the beginning of COVID and added hours, when we do have an outbreak, however, we usually see 3 casualties of staff not reporting back, unfortunately. But proactively staffing up has helped. We have COVID-19 staffing plans in place. If we do have, in our communities, if we do have a positive COVID case, and there's dedicated staff that are caring for those COVID-19 residents, we do have a hero pay rate that we pay those associates that are interacting with those COVID-19 residents, and that's helped a lot in our communities, and it only applies to the team that is directly involved with that resident or residents for the period of time that there is COVID-19 in the community.
Yeah, and we're in a similar situation for our facilities. There was already a nation and statewide nursing facility staff shortage. So we were already actively working on those solutions and had developed some contingencies. And again, us being the largest provider in the state, I think we have a couple of benefits that everyone doesn't have. So we're very fortunate in that, for example, we've got support staff at the regional and corporate level. We've got support staff at our other facilities. We can shift resources if we need to, and not everyone can do that. So it's much more difficult for these smaller operators. So speaking for our business, we've done the same thing. So in events where we have COVID positive unit, we make specialized contracts, and we do the COVID appreciation pay for our folks that are agreeing to work in there. But in all honesty, it is still very difficult. There's a lot of fear and a lot of anxiety, understandably, from our staff. And we try to make it a point to, like myself, for example, when I was asking them to move all these residents and work in the unit, I went back and worked in the unit myself and showed that obviously we can't expect them to do things that we wouldn't do ourselves. Mm-hmm. So we masked up, we put on our PPE to make sure that everybody is properly dressed. We did the hero pay, I think we just call it appreciation pay, and did that for those that are willing to do it. We always do volunteers. We try not to force anyone into it. Everyone's story is a little bit different. So for example, some of our employees have family at home that are more immunocompromised. So we would not expect them to be the first to volunteer. And just everybody in general it has a lot of anxiety. We've had a lot of really courageous, great staff that have stepped up to the plate and just want to provide care for our residents. And they've helped in a great way. We're not doing this, but some facilities, there is an allowance under CDC for if you get to catastrophic staffing levels to allow positive employees to continue working as long as they're asymptomatic, and as long as they're so many days past any symptoms, and as long as they're wearing full PPE. Luckily, we have not had to do that as of yet, and a lot of what we do is recover employees. And by recover, I mean they quarantine for 14 days. We test them at the end of that time frame, and if they're negative, we test them again, and if they're negative again, we're 2 tests 24 hours apart, we bring them back to work. So that's been the biggest thing. But obviously 14 days is a very long time, particularly if you have 15 positive employees that happen at one time that are full-time people. It can cause a significant issue. But with the staffing for the association in whole, everyone has reported similar issues that if they have sister facilities, they're able to reallocate resources and give them time to rehire and recover their employees. And in ones that aren't, they're really struggling quite a bit. But there is an agency that they've been able to use where they used employment agencies in some of the smaller operations to fill their holes. But I'll tell you, Miller, a big part of this is there were several employees that resigned their positions in their facilities. There were older nurses who decided, I was going to retire in 2 years. I'm going to retire now. And the nursing world is already something that we've been preaching for years. We don't have enough nurses coming into the field. We don't have enough nurses. And I think this is going to have a pretty big impact on that. I think initially for the negative, but in the long run, I'm optimistic that it's driven people to the nursing field, that it's created a passion for people to help, to be somebody that can be considered a hero in the healthcare world and do those things. And we're hoping to see those nursing enrollments continue to climb for the long run. But in the short term, it's definitely difficult. It's something that where everybody's stretched. People are working a lot of overtime right now to care for the patients, and across all sectors, in hospitals, nursing homes, and everywhere. And it's been quite a roller coaster. The ups of seeing people rise to the occasion, and the lows of seeing people decide to hang it up. It's been interesting.
Well, Katie, we're kind of out of time now. Are there any other questions that we need to let them address?
I think the chat works. I keep double checking to make sure it's working. I think y'all are just so thorough.
Okay. Well, I want to thank both of you. I mean, y'all are our healthcare heroes, Paige and Nick, and thank you for what you're doing. And maybe that positive feedback isn't what you are always hearing from families, but we're really grateful that there are such loving communities and places where people really care about their residents and their staff. That's really important too. You've got to protect, both. And, it sounds like, as much as we wish this was going to be over quickly, that I think at least in one form or another, it's not. It's going to be here with us for a while. And so we may be having you back in the future to talk about it when more time has passed. But like I said, we will have this webinar up on our website on Monday. And those of you that are watching live can be sure to help spread the word. And I know it'll be a helpful resource. So thank y'all so much.
I wanted to real quick interject just a reminder that if you are a nurse or social worker and you want a CEU, email Sherry Sparks at aca2@alzca.org. And you should be getting a survey once this is over. If you don't receive it, I have put it in the chat just in case it doesn't, because we've never sent a survey right after the webinar. This is the first time. And if you are not a nurse or a social worker and you need CEU credit, still email that email address and you'll get a certificate of completion you can submit to your board. And that's all I have.
Katie, thank you for helping with CEUs. Paige and Nick, thank you for providing such informative content. Appreciate it.
Yes, ma'am. Thank you.
Thank you.
All right.
All right.
Thanks, everybody. Everybody have a good, safe weekend, and wear your mask.
I'm not going anywhere.
That solves that. Thanks a lot.